Imagine going to a cosmetic surgeon, like absolutely convinced that a specific part of your body is deformed, and you think it needs to be, surgically reduced. You've been agonizing over it in the mirror for years. But then the doctor sits you down and says, actually, the part you're hyperfixated on is completely normal.
Yeah.
And the real problem is something entirely different, something you haven't even noticed.
Well, it happens every single day in this specific field of medicine.
Wow.
It turns out we are actually incredibly bad at self-diagnosing the source of our own bodily changes, especially, when those changes happen really gradually over time.
It makes me think about taking a car to the mechanic.
Okay.
Like if your car is shuddering and just handling horribly, to you, the driver, it just feels like the whole machine is falling apart.
Right.
You have absolutely no idea if you're dealing with the deflated tire, which is, a simple external padding issue, or if you have a blown transmission.
Yeah.
Which means the complex internal mechanics have completely failed. You just know it feels wrong.
And if you walk into the mechanic demanding they replace the transmission when all you really need is some air in the front left tire, you're setting yourself up for an expensive, unnecessary disaster.
Exactly.
And that is the fundamental dilemma we are looking at today.
Which brings us to the mission for this deep dive. I have been reading through this massive stack of clinical guidelines, cosmetic surgery journals. Specifically, there's this fascinating 2026 piece from the Aesthetic Surgery Journal.
Oh, yeah, that's a good one.
Plus all these psychological screening protocols and FDA warnings. And we're going to untangle a highly misunderstood area of medicine, female genital cosmetic surgery, or FGCS. Specifically, we want to understand how clinicians navigate the massive gap between what patients think they need and the anatomical reality of adding external labial cushioning versus repairing internal vaginal tightness.
The scope of this confusion is massive right now.
I bet.
If we look at the numbers from the 2023 ISAPS Global Survey, that's the International Society of Aesthetic Plastic Surgery, procedures branded under the umbrella term of vaginal rejuvenation have spiked by about 20% year over year.
20%? Wow.
Yeah. But the terminology circulating out there in the public sphere is just a mess. It's completely non-standardized and, aggressively commercialized.
Right.
So patients are walking into clinics blending entirely different anatomical structures into one imaginary procedure.
So we really need to start by drawing a hard line between the distinct anatomical problems patients actually bring into the clinic.
Yes.
Because you can't fix a problem if you don't know the difference between the outside envelope and the inside mechanics.
Exactly.
Let's look at the external issue first, which is clinically called labia majora augmentation.
Right. So the labia majora are the outer folds of the vulva. Structurally, the tissue here behaves very much like the tissue in your face. As a person ages, goes through menopause, or, experiences massive weight loss, those outer folds lose subcutaneous fat and collagen.
Ah, I see.
Estrogen drops, the tissue thins out, and the structural support just kind of fades away.
So it's essentially the same mechanism that causes your cheeks to hollow out.
Yes.
Or like your jawline to lose its firmness over time.
It is the exact same biological process.
Mm-hmm.
The result is deflation and tissue laxity. It's really a pure volume loss issue.
Right.
So the clinical fix for this is restoring that lost volume. A surgeon will usually take a patient's own purified fat, maybe from the abdomen or thighs, and transfer it into the majora to kind of reinflate that outer envelope.
Oh, okay.
Or they might use treatments like Renuva.
Yeah, I saw Renuva mentioned in the clinical guidelines. How does that actually work? Because it's not just a traditional filler, right? Like it's something different.
No, it's quite different. Renuva is an off-the-shelf adipose matrix.
Okay.
Think of it like injecting a microscopic honeycomb-like scaffold into the deflated area.
Scaffold, right?
Yeah, and over several months, the body's own native stem cells migrate into that scaffold and build brand new localized fat cells.
Wait, really? It builds new fat cells?
Yeah, exactly. The scaffold eventually just dissolves, leaving behind the patient's own living tissue. It biologically replaces what was lost.
Okay, so that's the deflated tire. It's an external padding issue solved by adding volume.
Right.
On the flip side, we have the internal structural issue, which is treated with a vaginoplasty. And this targets the internal vaginal canal, which, that's a completely different world anatomically.
It really is. A vaginoplasty is a serious reconstructive procedure. It addresses the internal muscles of the pelvic floor and the mucosa, which is the internal lining.
Okay.
When someone goes through childbirth, the pelvic floor muscles, which act like a sort of muscular hammock holding up the internal organs.
Right, they ham.
Yeah, they can separate and stretch significantly. So a vaginoplasty actually involves going in and suturing those separated muscles back together. You're tightening the connective tissue and removing excess mucosal lining.
Mm.
It's a lot like lacing up a corset to restore tension.
The sources mention women usually seek this out for functional reasons, right? Like dealing with severe looseness that causes a tampon to physically fall out,
Yes, exactly.
or wanting to restore friction and sensation during intimacy because the internal structure has just lost its grip.
Exactly. You're fundamentally repairing the internal architecture. But this brings us to the clinical revelation in that 2026 Aesthetic Surgery Journal article you mentioned.
Oh, yes.
Patients constantly confuse the internal structural issues with the external volume loss.
Yeah.
And this leads to a visual optical illusion that clinicians call the pseudoprotrusion phenomenon.
The pseudoprotrusion phenomenon, this completely blew my mind when I read it. Walk us through how this optical illusion actually happens.
So a patient will come into the clinic, highly distressed, complaining that their inner lips, the labia minora, have suddenly grown.
Okay.
They complain that these inner folds protrude way out, they chafe, they look completely different than they did 10 years ago.
Yeah.
And the patient wants them surgically chopped off and reduced. But upon clinical examination, the inner lips haven't grown a single millimeter.
The inner structure didn't change at all.
Not at all.
It's just that the outer envelope, the labia majora, shrank and deflated. It's like if you lose 40 pounds, your winter coat is suddenly going to hang way off your shoulders.
Yes, exactly.
Not because your arms got longer, but because the padding underneath is just gone.
That is a brilliant way to picture it. The outer padding deflated, unveiling the inner anatomy that used to be tucked away.
Right.
Now, if a surgeon were to just nod, agree with the patient's self-diagnosis, and surgically amputate those inner lips, it would be a catastrophic clinical error.
Because they're removing the wrong thing?
Exactly. It would permanently remove functional, sensitive tissue to overcorrect an anatomical structure that was never the root problem to begin with.
Mhm.
The anatomically honest fix is to restore the outer volume with fat or Renuva so it envelops the inner tissue again.
But hold on. Put yourself in the doctor's shoes for a second.
Okay.
If a patient comes in fully convinced she needs her inner lips reduced because they're sticking out, how does a doctor respectfully convince her that the real problem is actually a lack of padding on the outside?
It's tough.
Because she's been looking in the mirror for years, building up this narrative. You can't just tell her she's seeing things.
No, you can't. And that is the core challenge. The clinician's hardest job isn't making the incision, it's the consultation.
Right.
The consultation is this exercise in carefully aligning a patient's internal narrative with clinical reality. The first step is for the doctor to distinguish whether the patient is experiencing aesthetic distress, meaning they want to look flawless, or functional discomfort, like severe chafing when riding a bicycle, or the internal looseness we talked about.
And according to the guidelines from ACOG, the American College of Obstetricians and Gynecologists, and the RACGP in Australia, a massive part of that consultation is just educating patients on the incredibly wide spectrum of normal human anatomy.
Yes, normal is very broad.
The measurements in these papers are wild. A completely healthy, normal clitoral width can vary from 1 millimeter all the way to 22 millimeters.
Right.
And normal labia minora length can range up to 100 millimeters.
It's vital to put those numbers in perspective.
Think about that for a second if you're listening to this. Imagine if you were told that a normal, healthy adult shoe size could be anywhere from a size 5 to a size 25.
Yeah.
You instantly realize how absurd it would be to strive for one perfectly standardized ideal size. But patients don't know this because we just don't talk about it.
Which is why the Aesthetic Board of Cosmetic Gynecology, the ABCG, they publish very strict patient communication guides.
Oh, okay.
They highly advise using 3D anatomical models right there in the office.
That makes sense.
Because verbal descriptions often fail. But when a patient can physically handle a 3D model, the doctor can show them the exact mechanics of pseudoprotrusion.
Right, they can physically see it.
Yeah, they can physically demonstrate how adding volume to the outside changes the relationship to the inside.
The language they use during these demonstrations matters a lot too, right?
Absolutely.
The communication guide specifically trains doctors to use neutral vocabulary and to reframe denigrating terms.
Yes, that's key.
Like if a patient points and says, "I want to get rid of this extra saggy skin," the doctor is trained to reply by referring to it as sensitive tissue. It's this subtle psychological technique to deprogram the idea that the patient's body is somehow diseased or flawed.
Beyond deprogramming language, clinicians have to draw incredibly hard boundaries around what a procedure can and cannot do to manage the risk of dissatisfaction.
Right.
A patient must understand that an internal muscle repair, a vaginoplasty, is not going to fix the external chafing they feel against their clothing. And adding external fat to the labia majora won't do a single thing to fix pelvic floor prolapse or internal weakness.
I have to push back on this idealized version of the consultation room, though.
Okay, let's hear it.
Because we were talking about private aesthetic clinics. These doctors are running a business. Isn't there an inherent conflict of interest here?
Well,
Like, if a paying patient walks in with cash in hand, demanding an anatomically impossible or unnecessary surgery, how often is a private surgeon actually going to turn them away?
it's a cynical question, but it's a completely necessary one.
Right.
If we look at the clinical guidelines dictating safe medical practice, turning away patients with unrealistic expectations isn't just an ethical mandate. It's a legal and business necessity.
Wait, really?
Yeah, unmet expectations are actually the leading cause of patient dissatisfaction and subsequent litigation.
Oh, wow.
It outranks actual surgical errors or medical complications.
So a patient who heals perfectly, but is furious because her unrealistic fantasy wasn't achieved, is just as much of a threat to the clinic's survival as a botched surgery.
Often a bigger threat, honestly. Safe practice requires tethering expectations to reality. But sometimes, a mismatch in expectations isn't just a failure to understand anatomy.
Right.
Sometimes a patient simply refuses to believe the anatomical reality even after seeing the 3D models and hearing the data.
Wow.
And that is when a misunderstanding crosses the line into a glaring psychological red flag.
Which brings us to the psychological guardrails. What exactly is that red flag?
The primary red flag is body dysmorphic disorder, or BDD.
Okay.
This is a psychological condition characterized by a severe, obsessive preoccupation with an imagined or incredibly slight defect in physical appearance.
Right.
And according to the data from ReadyMind, they're an organization that provides psychological screening tools for cosmetic clinics. BDD is the most significant risk factor in cosmetic surgery today.
The statistics from ReadyMind are genuinely grim. Like, I was reading this, and their data shows that 82.3% of individuals with BDD who undergo a cosmetic procedure experience absolutely zero improvement in their mental health.
None at all.
Or their mental health actually deteriorates post-surgery.
And the physical outcomes are worse, too.
Right.
BDD patients are at a 3 times higher risk for severe post-operative pain and surgical complications compared to patients without the disorder.
Wait, why would a psychological condition cause a higher risk of physical surgical complications and physical pain? Like, how does that work?
It comes down to the mind-body connection and how the central nervous system processes trauma.
Okay.
Because BDD involves obsessive hyperfixation on the perceived flaw, the patient's nervous system is already in a heightened state of distress.
Right.
So after surgery, they hyperfixate on the healing tissue, the swelling, every tiny sensation.
No, I see.
This anxiety amplifies nerve signals, turning normal post-op discomfort into severe chronic pain. It also leads to behaviors like constant poking, prodding, or checking the incision site, which introduces infection and ruins the surgical outcome.
That makes total sense. The obsession physically interrupts the healing process.
Exactly.
Which is why medical boards are now urging clinicians to use a specific screening tool called the BDDQAS, the Body Dysmorphic Disorder Questionnaire for Aesthetic Surgery.
Yes.
It is this brief 7-item questionnaire that takes about a minute to fill out in the waiting room, and it boasts an 89.6% sensitivity rate for detecting BDD.
It's very effective.
Yeah.
And it asks very pointed questions. It screens for extreme preoccupation, like, are you thinking about this flaw for more than an hour a day?
Right.
It checks for compulsive behaviors like mirror checking or skin picking.
Yeah.
Most importantly, it assesses whether this perceived flaw is actively impairing their daily social or occupational life. Like, are they avoiding going to work or avoiding intimacy because of it?
It's kind of like walking through a metal detector at an airport.
Okay, yeah.
The metal detector doesn't definitively diagnose what the specific threat is. You know, it doesn't print out a report saying this person has a pocket knife.
Right, right.
But it flashes a red light that definitively alerts security that this person needs a much closer secondary screening before they can be allowed to proceed to the boarding gate.
That is the perfect analogy. But it introduces a massive communicative challenge for the doctor.
How so?
Well, if a patient sets off that metal detector, if they screen positive on the BDDQAS ACOG guidelines mandate that the surgeon must refer them to a mental health professional for a full evaluation, before any surgery can be considered.
Oh, man. Talk about a delicate conversation.
Very.
The patient came in looking for a physical fix, ready to book a surgery date, and the doctor essentially has to say, I want you to see a therapist instead.
It's incredibly hard. The clinical guidance stresses that this referral should never be framed as a rejection of the patient
Okay.
or a dismissal of the very real pain they are feeling. The surgeon is trained to frame it as the safest, most compassionate next step in their overall care.
Right.
The message has to be, my primary job is to improve your well-being, and based on what you've shared, surgery is not the safest path to achieve that well-being right now.
We have to zoom out for a second, though, and ask why.
Okay.
Like, why are so many patients walking into these clinics so deeply confused about their internal versus external anatomy and carrying such unrealistic, sometimes psychologically damaging expectations?
It's a great question.
Reading through the stack of sources, the culprit is glaringly obvious. It is the relentless, unregulated commercialization of these procedures.
Oh, absolutely. Direct-to-consumer advertising and internet marketing have completely warped the landscape of patient expectations.
Right.
Commercial clinics are inventing vague, highly branded terms. You see menus offering a designer vagina, a barbaplasty, or vaginal rejuvenation.
Terms that mean absolutely nothing in a medical textbook.
Nothing at all.
Yeah.
These catch-all phrases blend complex internal muscle reconstruction and external cosmetic fat grafting into one confusing, glossy menu item. They present a major surgery as if it's a standard facial at a local day spa.
And ACOG is fiercely critical of this. In their committee opinions, they specifically call out the rebranding of traditional medically indicated surgeries.
Yes.
Let's look at a procedure like an anterior or posterior colporrhaphy.
Right.
In a traditional hospital setting, that is a heavy medically necessary surgery to repair a prolapsed vaginal wall, literally fixing a hernia where the bladder or rectum is pushing into the vaginal canal.
Exactly.
But cosmetic clinics are rebranding these heavy functional repairs as trendy rejuvenation procedures.
And by using the word rejuvenation, the marketing implies a return to youth.
Right.
It normalizes a prepubertal aesthetic.
Yeah.
Like a hairless, perfectly symmetrical, tucked-in appearance that simply doesn't exist in most mature, healthy adult bodies.
It's crazy.
It manufactures what the literature calls genital anatomy anxiety. They're essentially selling a cure for a disease that the patient doesn't actually have.
But it's not just the aesthetic ideals that are dangerous. It's the specific technology they are marketing as quick fixes.
Oh, the lasers.
Yeah, this part of the FDA warning really stood out to me. Patients are reading brochures about laser rejuvenation, and they assume it is a quick, non-surgical spa treatment you can get on your lunch break.
Right.
But the FDA actually issued a strict, formal warning in 2018 against using energy-based devices, like lasers and a radio frequency, for vaginal rejuvenation.
They did.
They warned it could cause severe vaginal burns, massive scarring, and chronic, long-lasting pain during intercourse.
We have to look at the mechanism of how these lasers work. Marketing often pushes fractionated CO2 lasers.
Okay.
On the face, these lasers work by poking microscopic holes, micro-injuries, into the epidermis to trigger the body to produce collagen. As it heals, it smooths out wrinkles.
So they took a facial technology and just assumed it would work exactly the same way inside the body.
Essentially, yes.
Uh-huh.
But internal mucosal tissue is fundamentally different from facial skin. When you use a fractionated laser to cause micro-injuries inside the vaginal canal, you aren't just smoothing out a wrinkle. You run a very high risk of generating thick, rigid scar tissue.
Oh, no.
Yeah, you are taking a structure that relies on elasticity and suppleness, and you are creating permanent rigidity, which leads to chronic friction burns and pain.
So how does a doctor deprogram that? Like, a patient is sitting there with a glossy brochure that promises a quick laser fix, and the doctor has to manage that expectation.
It comes down to the critical difference between reading marketing copy and signing informed medical consent.
Okay.
A marketer's only job is to sell a solution. A clinician's duty is to be the anchor to reality.
Right.
When a patient demands the laser treatment, the doctor has to strip away the buzzwords.
Yeah.
They have to explain the exact biological mechanism of what a fractionated CO2 laser does to internal mucosa, what the FDA warning specifically says, and what permanent loss of elasticity actually feels like.
Wow.
It's about replacing the glossy brochure with clinical truth.
It is an incredibly complex landscape to navigate, but I think we've done a solid job of untangling the core issues today.
I agree.
Our mission was to understand the expectation gap in female genital cosmetic surgery. We've clearly separated the anatomy. Adding an external volume cushion to a deflated labia majora is an entirely different biological process than repairing separated internal vaginal muscles with a vaginoplasty.
Right.
You can't fix a blown transmission by inflating the tires.
You really can't.
Yeah.
And we've also eliminated the immense burden placed on the clinician in the consultation room.
Yeah.
The surgery is almost secondary. The primary job is educating patients on anatomical diversity, using psychological screening tools like the BDDQAS to protect vulnerable individuals from harm, and constantly pushing back against the misleading, rebranded narratives aggressively pushed by internet marketing.
Which is exactly why understanding this is so crucial for the listener. Whether you are prepping for a medical consultation yourself down the road, or you just want to be a well-informed consumer of healthcare, understanding the vast natural spectrum of normal human anatomy is your absolute best defense.
Right.
It protects you against predatory marketing that tries to sell you an invasive fix for a body that isn't broken.
Knowledge is the only antidote to that kind of commercialization.
Absolutely. Before we wrap up, I want to leave everyone with one final thought to mull over.
Okay.
Something that builds on the mechanisms we've discussed today but wasn't explicitly answered in the guidelines. We talked extensively about labia majora augmentation, specifically using a patient's own transferred fat to restore volume to that outer envelope.
Right.
But we know that fat cells in the human body are living tissue. They expand and shrink in direct response to your overall weight fluctuations.
That's true.
So, if a patient gets this external fat transfer procedure to fix deflation and then experiences a major weight change, say gaining or losing 50 pounds 5 or 10 years down the line, does that augmented transfer tissue expand or shrink with them?
Oh, wow.
Right. Could the cosmetic fix for volume loss eventually turn into an entirely new, unpredictable anatomical distortion as the patient ages and their weight fluctuates? Something to think about.